My presentation, this is the outline. I'll do an introduction, the problem statement of my survey, and let me go back to read the survey. It's a pilot descriptive analysis of the readmitted kidney transplant recipients at the Kenyatta National Hospital. Let me start by just an overview of transplantation, so I'm sure some people have already specialized in other other therapies that are there for kidney, like Garoia and others are doing PD. So let's just do an overview first of renal replacement therapy. That when you have end-stage renal disease, the option is either hemodialysis, peritoneal dialysis, or kidney transplant. In kidney transplant, the option could be living, where you and a relative or any other living person works in our theater, or deceased, where the program exists for deceased donor, where there is the person could have involuted into death from cardiac death or brain death. And in living, you can either have related or non-related. This is the hospital I work in. The Kenyatta National Hospital is one of the two, for the sake of our visitors from Africa, is one of the two referral centers. This is around the central part of the country, and there's another one in the west called Moi Teaching and Referral Hospital. It's both it is also the training center for the University of Nairobi. That is why I projected this picture from the side of University of Nairobi. That's how it looks like at night. I like this picture better. This is how we have organized our transplant program. We have the head of surgery, and in surgery we have vascular surgery, we have urology, we have head of nephrology nursing, because nurses are key in provision of transplant services. We have head of anesthesia, and we have head of nephrology, which is also the chairperson of the transplant team. In here, the big circle, we have the transplant coordinator, which now is my job with the patients there. So we are just dealing with it. It's such a complex program, but we are just there with the patients and getting instructions from all direction and communication. Our transplant clinic, this is how it's organized. We take care of the pre-transplant patient preparation, peri-transplant when they come for admission, and post-transplant follow-up. And in pre-transplant, we either get referrals from anywhere in the country. We just don't transplant Kenyatta Hospital patients. We have in-house our own patients or referrals. And post-transplant, we also have patients who have transplanted ourselves. Others are referred. Maybe they transplanted in another center, but our center is nearer to them, or overseas, mostly from India. They still come for follow-up there. When we have successes of the transplant program, which began in 1984, but it was upscaled in 2010 through a public-private partnership with Novartis Pharma and doctors from Spain, Barcelona. And we have had 1,200 patients who have benefited so far. Transplantation was made the hospital's 2030 flagship project. Those ones who are in the country knows what it is. They want, if you hear about Kenyatta National Hospital, you just relate to transplant with it. Same way we have centers that relate to cardiac, like the current hospital in Mata. We have 2 transplant teams in place. We established a transplant coordination office in 2011. Pediatric transplantation is normally a bit challenging because of the vessels, affordability. Sometimes they come from broken homes. Nobody can be able to pay for their transplant. And so we transplanted 9, I think is a plus for us, but now they're already adults. They have already transited. We have had a second transplant, somebody whose first kidney failed because of obstruction. We have attracted more public-private partnership that we have had, like banks partnering with us more. And these activities are what formed the foundation of East Africa Kidney Institute. They noticed that if they were to choose how to help East Africa in caring for the non-communicable diseases, Kenya was already ahead, and they decided to choose it for kidney. In Uganda, they chose it for oncology, and Tanzania for cardiac. There have been training of nurses in coordination and immediate post-transplant care in India. Most of them we have taken the fourth nurse will be going to India, Apollo, in the next 1 month. Originally, our unit was built in the 70s, and it was just a dialysis unit. And all these numbers, you have done them in a small room. But now we have had an expansion, and this is a center that is being launched in the next 1 month or two for transplant, or transplant only, and it is a 17-bed unit with 10 acute beds, 5 step-down or readmission ward, 2 isolation beds, an outpatient clinic, renal lab with HLA tissue typing. Most of these services, we've been sourcing them from South Africa or India. And it also has a resource center for students and theaters. Introduction of my presentation now. Renal transplantation is a treatment of choice for, I don't know what's happening, for majority of patients with end-stage renal disease. The kidney transplant recipients have higher admission rate than the general readmission than the general population because of the immunosuppression. They are more prone to infection, graft dysfunction. Infections continue to be the main cause of post-transplant morbidity and mortality. Readmission rates after transplant vary by center, by the donor. Are our donors deceased or are they living? And the recipient factors, like are they, do they have a problem with where they are living? Are they observing infection prevention measures? Are they affording treatment? And they have diverse causes. The problem is that we have noted an increase in the number of kidney transplants done per year as seen in other centers around the world. Increases burden on the few nephrologists, and patients are more likely to be seen by primary care physicians. There's no research on reasons for readmission in kidney transplant recipients at KNH Kenya, and few data from Africa as a whole. And the survey aims at describing the final diagnosis of readmitted kidney transplant recipients to inform clinicians of the diagnoses and also help in focusing continuous medical education for all cadres in this diagnosis and to improve the care of these patients. The data describes will also form a basis for larger case series study for whole cohort to further describe association and possible risk factors to be readmission. In the morning, there was that speaker who was talking about let's sometimes be knowing problems before we wait for people to come with infection. Can those reasons, if we knew them upfront, are they preventable? That is the whole aim of this survey. Method, it was just a retrospective descriptive survey at the Kenyatta National Hospital. We've talked about that. Within 1 financial year, 2 financial years, we recorded all the 40 transplant recipients' medical records for the period July 2016 and June 2019. The data collection and processing were from charts, from the coordinators' reports, and using abstraction form put into the database. The exclusion was elective admissions. Anybody who was coming like for stent removal or something like that. Variables were, there were demographics differences, age at transplant, primary diagnosis, final diagnosis at discharge. The results, these are the results. 40 records were reviewed. Majority of the patients we observed were male. Majority were transplanted from KNH. Mean age at transplant was 38 years, as you can see in that chart here. We have had several patients from India, Karen, KNH, and others. I can't see properly. Nairobi Hospital, sorry. The primary diagnosis, most of our patients, the cause was hypertension. And it's good to note that what we call hypertension sometimes is just glomerular diseases. You ask a very young person, below 30 years, how did you get your disease? Oh, I just came to hospital, I was feeling unwell, my pressure was high. After how long? Did you ever know that you had hypertension? No, it was just, I've never known to be hypertensive myself. Such that now that, in the absence of a biopsy, it must have been a glomerular disease, rapid progressive glomerular disease, chronic glomerular nephritis, and all that group of diseases. We also had, the other big group was also from diabetes. And also, it's also good to note why hypertension also reads like it was more, because you can also be diabetic and hypertension at the same rate. Others were polycystic kidney disease, and the others were obstructive uropathies. On the discussion, our survey gives a sneak peek into reasons why transplant patients are admitted. Hypertension, CKD topped the list of the primary diagnoses. Renal transplant recipients were diagnosed with infectious processes often. In this population, complications from surgical procedure was nil. Surgical procedures, we normally find it as a complication immediate post-transplant, but after they have been discharged, rarely will they come back with a surgical complication. In conclusion, Kidney transplantation is not without complications, as we are talking to our patients recommending transplant. Clinicians should be well versed with common reasons for admissions and emergency care in kidney transplant recipients, and a larger study should be done to describe admission symptoms associated with factors to admission in order to inform the clinician earlier. I think there is this slide that I did not describe. So when our patients came, these were the reason as to why, the highest reason as to why we were readmitting them was graft dysfunction. This is somebody who left with a certain level of creatinine, but they have risen with more than 20%. That was the highest cause. Blood-borne diseases, these are pneumonias, infections, rising WBCs. Urinary tract infection was also a lot. Gastroenteritis, dermatosis. This is where we grouped chickenpox, herpes as dermatosis, and post-transplant diabetes. We have had, we've been calling it NODAT, newly onset diabetes after transplant, but now they have changed that name again to post-transplant diabetes. We've not had a recurrence of the native disease. Maybe it's because our survey was within a very short time, and these are the ones that we had grouped them like malignancies, hernias. We did not get any patients on them. So the end of my presentation.